Hello and welcome everyone. Today we'll be discussing thrombocytopenia in sepsis. First, how to measure platelets. Platelet count measures the number of platelets per a volume, typically analyzed by automated instruments. Abnormal counts are repeated manually, that is, they're counted manually. Then the reported counts are quantitatively reported. Platelet function. Platelets can be dysfunctional irrespective of their count. Now, they are affected by drugs, intrinsic platelet dysfunction, renal and liver disease, unfavorable environment. So, you need some specialized assays for measuring platelet function. Viscoelastic testing provides a qualitative insight but has controversial clinical relevance. Now, prevalence of thrombocytopenia in sepsis. In ICU patients, having a platelet of less than 1500,000 is very common, and it is seen in around 55% of the septic cases. Higher rates are observed in patients who develop shock. Severe thrombocytopenia in sepsis, that is less than 50,000, occurs in around 30% of these thrombocytopenic septic patients. And there is a close relationship with the outcome, that is, thrombocytopenia is associated with worse outcomes. And early or sustained thrombocytopenia has worse prognostic significance. So, utility, uncertainty in causality. Now, whether this low platelet is a cause of worse outcome or it is the effect of the disease severity, which ultimately is the cause of thrombocytopenia and worse outcome, is not something which is clearly understood as of now. But we do have some complications that are associated with thrombocytopenia, that is increased coagulation related complications. When the counts are less than 100, there is always a fear of bleeding if there is any procedure going on in the ICU. So if you find these patients, that is a ICU patient who is septic, who is having a low platelet count, you are definitely worried. So the role of platelet in sepsis and thrombocytopenia. Platelets are crucial for homeostasis and inflammation. Now, the immune mediated platelet activation is a key infection response. Platelets interact with the immune as well as the complement systems. Platelet function in immune response is very vital. The release agents that promote neutrophil activation and leukocyte recruitment are released from the platelets. They express pattern recognition receptors, stimulate neutrophil extracellular trap formations, severe thrombocytopenia, and impact on patients' immunity. Severe thrombocytopenia is usually a effect which is seen in patients who have dysregulated host immune response, that is sepsis. There are altered gene expression in septic patients, and it includes reduced leukocyte adhesion, increased complement signaling. So the low platelet itself has a key role in both being a factor for increasing the inflammation as well as getting reduced, especially functionally and as well as in number, when this inflammation rises. Now coming to the vascular integrity. Safeguard vascular integrity. The platelets, they safeguard the integrity of the vessels by optimizing the barrier function. Now, the reduced extravasation of water and protein is seen especially during inflammation if the platelet function is preserved. So directly blocking the gaps in the vascular lining and maintaining the endothelial structure, platelet prevent the extravasation of the fluids and plasma proteins. They release soluble factors that enhance this endothelial barrier function. What happens is that when there is a thrombocytopenia, the loss of this endothelial support reduces. As the count goes down, the platelets are unable to clog these gaps, prevent the glycocalyx damage, and resulting in extravasation of water and protein. So there is edema and tissue hemorrhages. So there are multifactorial phenomena which lead to irreversible platelet expenditure in the immune response. So there are some other etiologies, means apart from the inflammation that we have discussed till now, there are other reasons why the platelet can go down. That is disseminated intravascular coagulation. So there is a problem with the coagulation pathway. Mind you, inflammation and coagulation are very closely linked. It's not that every case of inflammation will be associated with DIC, but then it is definitely a subset under the broader subset of sepsis, where a patient along with the inflammatory disorder can also develop coagulation disorders. So once that coagulation disorder develops, platelet can develop a low platelet count. The next is reactive hemophagocytosis. So there are possibility of having changes in the bone marrow. So when there is a hemophagocytosis, that is because of the inflammation, there is destruction of the cells inside the marrow. So new cells are produced, resulting in thrombocytopenia as one of the most common features of hemophagocytosis. Now, prothrombotic condition cannot be ruled out in the background of thrombocytopenia. So because there are other causes which can cause this thrombocytopenia, like heparin-induced thrombocytopenia, which is a prothrombotic state. You can have immune-mediated TTP, again a prothrombotic state. And finally, you can hemolytic uremic syndrome, again a prothrombotic state. So again, a septic patient with low platelet, very difficult to know the patient is going to have a bleeding problem or patient is going to have a thrombotic problem. So there are some additional causes like drug-induced thrombocytopenia, immune-mediated thrombocytopenia, hemodilution by the fluids that we give, pseudothrombocytopenia because of other errors, extracorporeal devices like ECMO, CRRT, different devices, underlying hepatosplenic disease which has not been disclosed till now, or places of malignancy or myeloproliferative disorders. So based on all this, there can be a various causes which can be the reason why a patient has a low platelet count in my septic patient. So one of the most common things that we do is go for a peripheral smear, which gives us a lot of information. And if the things still don't get resolved or we cannot figure out what is probably the cause, we can go for a bone marrow aspiration as well. So drug-induced thrombocytopenia is a totally different entity. It is responsible for around 10 to 20%. Again, the most common things that will be involved are the antibiotics, because again they are the mainstay of our treatment. So it is going to be crucial to understand which of these are going to cause the problem, like vancomycin, antifungals, linezolid, beta-lactams, ciprofloxacin. All of these can cause a thrombocytopenia. Now when I get a thrombocytopenia, I really need to think now, and if I'm suspecting as this particular drug to be the reason for my thrombocytopenia, I have to weigh my pros and cons of killing the organism or treating the sepsis versus the complication of thrombocytopenia. So in case of severe thrombocytopenia complicated by bleeding, then you need to treat it. Typically occurs 5 to 10 days after the drug exposure. So the management here would be to stop the drug if feasible. This is very important. In case of severe bleeding, you need to administer platelets and consider IVIG and steroids in complicated cases. So keep all these things in mind, because it is not that in every case we can stop the drug. Next is the coagulation activation in sepsis versus DIC. Now, both immune and coagulation systems are activated in sepsis, that we have already discussed. Coagulation response in sepsis is a continuum. It's not that it just ends by the initial episode. So DIC represents an extreme and overwhelming and injurious coagulation response. The characteristics of DIC is a widespread coagulation, often involving bleeding, typically oozing from injection sites and wounds. Management of DIC would need to treat the precipitating factor. No specific treatment other than that. Monitoring the coagulation status is vital. So administering thromboprophylaxis when possible is important, because it is also a prothrombotic state. So you have to weigh the patient, see whether the patient has a more bleeding risk or a thrombotic risk, and manage accordingly. Regarding thrombocytopenia versus DIC in sepsis, Thrombocytopenia in sepsis does not necessarily indicate that there is a DIC, and ISTH DIC score can be helpful in case of doubts. So it's not that every thrombocytopenic patient is having DIC. Again, you have to see the clinical pictures, do your scores, check the risks, then only you will be making the diagnosis. Regarding bleeding risk in thrombocytopenia, there is a high risk of bleeding when there is increased severity. Severe thrombocytopenia is an important association of bleeding. So the factors that can influence are the correlation with platelet nadir is not always linear. It's not that a patient who has a platelet of 5 is definitely going to bleed and a patient who has a platelet of 30 is not going to bleed. So the values may not be very typical. Bleeding risk is influenced by the mechanism beyond the platelet count. The reason why the platelet count has gone down is going to be a pretty important cause. Alternative mechanisms include endothelial dysfunction as well. So in clinical observation, septic hematological ICU patients report higher incidence and severity of bleeding compared to non-ICU hematological patients with similar thrombocytopenia. So in being in ICU, being inflamed has an increased risk of bleeding. Regarding thrombosis risk, sepsis is a risk factor for thrombosis as well, even in presence of thrombocytopenia. One study found that 7.5% of the thrombocytopenic patients develop a new thrombi versus 4.5% of non-thrombocytopenic patients. So patients who are thrombocytopenic, they have an increased risk. So the study on hematological malignancy shows that thrombocytopenia is generally associated with lower thrombosis incidence. Increased thrombosis risk is seen in ICU patients. So it is the inflammation which will increase the risk of thrombosis. And uncertainty in thromboprophylaxis remains. It is unclear whether we should give thrombocytopenia prophylaxis to these patients or not. So the next is platelet transfusion in sepsis. Transfusion carries a risk, often inefficient at increasing platelet counts. So we must keep these things before we transfuse. It is not recommended unless the patient is bleeding and the thrombocytopenia is severe. Increased mortality rates are reported in septic patients receiving platelet transfusion. The causality remains unclear. Regarding prophylactic transfusion, trial has shown difference in catheter-related bleeding, suggesting some benefit of transfusion. Guidelines suggest transfusion to achieve platelet count more than 20,000 for CVC placement or other low-risk procedures, and a platelet count of more than 50,000 for high-risk procedures and lumbar puncture. Thrombocytopenia in sepsis is common, but many uncertainties remain. Association between thrombocytopenia, bleeding, transfusion, and mortality follow a dose-response pattern. Worse outcomes accompany more severe thrombocytopenia, but the causality is not yet established. Advances needed for better understanding and support of septic patients with thrombocytopenia. So before we end, I will give you a flow chart of how to manage the thrombocytopenic patient in ICU. So based on this algorithm, first you should do an initial assessment, confirm that there is a thrombocytopenia, rule out any lab errors. This is the first thing. Confirm the thrombocytopenia, rule out the lab error. Next, see what is the severity, whether it is mild, moderate, or severe, or critical. Once you have done that, try to find out the causes, whether I have septic causes, that is immune mediated, DIC, must have some coagulation problems as well. Do the scoring systems, check for other cytopenias, try to find out if there is a reactive hemophagocytosis. If you are thinking that it is not likely a septic cause, my patient is not that sick or probably not that septic to develop these problems, you can look for non-septic causes, the most common being drugs again, and most common drug being the antibiotics. Heparin, a common factor. Immune-mediated thrombocytopenic purpura is important. HUS and underlying conditions must be kept in mind. So once you have figured out what could be my possible causes, take a proper history, send peripheral smears, do specialized viscoelastics tests, do your scorings, and finally, if nothing comes around and you are still clueless regarding what's the diagnosis, probably it's better to go for a bone marrow aspiration. Regarding indications of thrombocytopenia and platelet transfusion, if the bleeding is present, then transfuse. If platelet count is less than 20 and you want to put a CVC, give platelet and then do. If for lumbar puncture and high risk procedures, less than 50. but monitor the adverse effect as well as the efficacy of transfusion. This is important. Do monitor the efficacy of transfusion. Finally, monitoring and follow-up. Regularly monitor the counts as well as the clinical status of the patient. Adjust treatment based on patient's response and emerging complications. Reassessment is needed for ongoing platelet transfusion and thromboprophylaxis. Thank you for your patience.